So good night, everyone. Welcome to GREX Trainee webinar. The Global Renal Exercise Network, GREX, consists of researchers, medical and allied healthcare professionals from around the world who aim to foster collaborative research and innovation across multiple disciplines. One of the GREX main objectives is to develop effective strategies to increase physical activity and optimize health outcomes in people living with a kidney condition. Therefore, to engage more researchers and professionals, GREX decided to initiate GREX Trainee webinar. The purpose of the webinar is to provide the junior GREX members opportunities to present their research to an international audience. Due to the COVID-19 pandemic, one of the aims of this webinar is to provide the opportunity of presenting studies that were submitted to conferences that have been cancelled or postponed. For the last month, several studies have been presented at GREX Trainee webinars, as you can see. Presentations from Tom, Špela, and Tiago, that is representing Bianca. Each abstract presentation is allotted 10 minutes, followed by an additional 5 minutes of audience question and answer. If you want to make a question, please send it on the chat. For specific questions about GREX or about collaborations, there will be also 15 minutes at the end for a casual networking time. So now let's start with Clara Boom, that will present her lab. Clara, if you are...
I'm here, yeah. I'm just getting the screen shared. Can you see it? Can everyone see?
Yeah.
Yep. Okay, all right. Thanks very much for inviting me to do just a quick talk about my lab. It's not really a lab, it's a research center because we are all doing clinical research. Trying to move it forward and it's not. It's located in Winnipeg, Manitoba, Canada, which is actually the geographic center of North America. Because it's in the Northern Plains, it's very, very flat and very cold in the winter, although beautiful. In the summer, it's still flat, but it is smoking hot during the day and the days are incredibly long. Winnipeg is a city of 800,000 people. It's very culturally diverse. And when there's not a COVID-19 pandemic going on, it has an incredible number of festivals, both cultural, arts, musical, and great food. It is also located and surrounded by lakes, rivers, and wilderness. And so for somebody who is outdoor powered like me, it allows us to get into the backcountry and cottage country quickly to recharge. I'm going to spend a moment talking about my path to an academic career because it is very different than what's traditional, and I think it's important on a trainee seminar. When I finished my clinical training, I actually, despite my interest in research and activity in research, decided to work half-time clinically in order to be able to be at home and raise my young family. When my youngest went to school full-time, I went back to school and completed an MPH at Hopkins School of Public Health, focusing on epidemiology and behavior change because I was already involved with exercise programming at that time. My first independent academic research appointment came in 2014, and I'm now a clinician scientist with 50 projected time. That although you can once, if you're patient and over time, it is possible to do everything you want. The goal of my research program is to characterize the effects of exercise on people with kidney disease and to use the results of these studies to implement clinical programs that will improve health outcomes. The current focus of my research at the moment is really on looking at functional status, symptoms, and cognition in people on hemodialysis. However, this all started in 2005 when there was actually a patient-driven initiative and the MRP became the first program in Canada that hired a kinesiologist to develop and run exercise programs. Over the years, we've developed evidence-sustainable programs, and we've worked a lot with the Edmonton and Calgary programs that developed around the same time. We now have 3 kinesiologists working with us in the MRP, and we have a host of programs that have been around for a while, The Kidney Fit video series, by video, is a cycling journey that has been going on for a long time. We actually use an integrated knowledge translation approach that incorporates a lot of evidence with our research program, and it allows us to move information back and forth between the clinical and the exercise programs. Over the years, this approach has really allowed us to develop evidence and expertise and methodology, and also to ask really important and relevant questions because we are interacting with patients all the time. Such an approach led us to be the first team to identify that intradialytic exercise actually helps minimize or reduces hemodialysis related cardiac stunning. Current projects that are extensions of these types of projects include a randomized controlled trial that is nearly complete now, which is investigating the effect of a 26-week exercise rehabilitation program on symptom burden in hemodialysis patients, and actually a recently newly funded CIHR trial, which is multi-center and international, investigating the impact of 12 weeks of intradialytic cycling on hemodialysis-related myocardial stunning. Our team at the Chronic Disease Innovation Center includes clinicians, scientists, and research staff with expertise in, list them all, but a few engineering and we and these students to be the scientists of the future and to have the skills to be able to succeed. Finally, we work with national and international co-investigators and collaborators to really try to ensure that the research results that we produce and the programs we develop are scalable and can be generalized to diverse settings, both nationally and internationally. And so with that, I'll close. Thank you for listening. That's a little snapshot. I'd be happy to answer questions whenever it's appropriate. And when it's appropriate and the COVID-19 pandemic is over, come to Winnipeg and see what we do. It's a great place. Thanks.
Thanks, Clara. If anybody wants to do a question, please send. Where he oversees the running of various studies and supervises other team members. Amongst these, he also teaches on the master degree.
Thanks, Daniela. To share my screen. Introduction to the UK, from Leicester in the UK. I'm going to spend the next 10 CKD, and this is using the UK Biobank. So just as a little bit of a background for those who don't really know what sarcopenia is, it comes from the Greek phrase meaning poverty of flesh in skeletal muscle mass. But really that definition is constantly changing and has really been marked by 3 key milestones over the last decade or so. So firstly, in 2010, there was the addition of muscle function into many of the different consensus definitions of sarcopenia. So this started to move it away a little bit from the idea that it was just about muscle mass. In 2016, sarcopenia was given its own ICD-10 code. And then more recently, there's been a change to muscle function being the key criteria in defining probable sarcopenia. Probably the most widely used criteria is the European Working Group's definition. This was updated in 2019, as I've said. And they really advocate this approach where we are looking to find people with sarcopenia, assess them, confirm its prevalence, and then look at its severity. And they have a very nice flow diagram that they use, or that can be used to do this. And so firstly, what we'd be looking to do is we'd be looking at measuring muscle function, and this is usually by a measure of grip strength. And this would tell us if somebody has probable sarcopenia. We'd then be looking to confirm its presence, and this is usually done by a measure of muscle mass, particular appendicular skeletal muscle mass. So that can be done by things like DEXA. And then we're looking to grade its severity. So this is done by a physical performance test, most typically a gait speed or a timed up and go test. So a little bit of background to what the study that I'm going to describe. So we know that CKD is often described as a model of accelerated aging, but the idea of sarcopenia is somewhat under-recognized in those with CKD, partly due to the different definitions used, the fact that there's no real formal assessment, and often it's confused with other terms such as cachexia, malnutrition, or protein energy wasting. But we know that between 20 and 50%, depending on the criteria, of patients with CKD have some form of low muscle mass. But there really is a lack of research at the minute using these latest criteria, particularly the focus on muscle function. So the aim of our study was to explore the prevalence of sarcopenia, potentially identify any risk factors, and then explore the association with all-cause mortality and end-stage renal disease. So we used the UK Biobank, and we looked at over 400,000 individuals that had a creatinine value in that cohort. We were able to find just under 9,000 participants with chronic kidney disease, and that left 419,000 without kidney disease. Sarcopenia was defined using the European Working Group criteria, but also the Foundation of National Institute of Health and Sarcopenia Project criteria. So that was probable sarcopenia, which we defined as low hand grip strength. We looked at confirmed sarcopenia, so that was looking at low muscle mass. And then we looked at severe sarcopenia, so we took poor walking speed as a measure of physical performance. We were able to look at all-cause mortality and also the date of reaching end-stage renal disease, which we defined as the need for dialysis or a transplant. And this was over a 9-year follow-up period. So as I'm about to show you in the next slide, you'll see there's quite a low prevalence of confirmed and severe sarcopenia. And also there was quite a low number of events. So a lot of the analysis I'm going to present is primarily on probable sarcopenia. So that's the low hand grip strength component of the criteria. So this is the prevalence that we found. So this is taken from a paper that's just been accepted in journal Cachexia, Sarcopenia and Muscle. So it should be online very, very soon. But you can see a couple of things I'm going to point out. Firstly, the prevalence of probable sarcopenia is double that in those without CKD, so 10% plays 5%. But as I said, you'll notice that when we get down to confirmed sarcopenia and severe sarcopenia, the prevalence is less than 1%. And they're very low numbers. There's a couple of reasons why this might be, but personally, I think it's more likely to do with the healthy responder bias of the biobank. This figure shows potential risk factors that we're able to measure. So the green circles are significant risk factors. The black circles are insignificant, and the black squares are the reference values we used. These are presented as odds ratios. So anything to the right of that dotted line is essentially the increased likelihood of being sarcopenic. And then anything to the left is a reduced likelihood of being sarcopenic. So I'm just going to draw your attention to a couple of things on this. Firstly, the biggest risk factor, if you like, for sarcopenia was physical inactivity. So we found that participants with the highest quartiles of METs per week, so those were the most active, had a 43% less likelihood of being sarcopenic. And the other biggest risk factor was multimorbidity. So we found that participants with 3 or more comorbidities were twice as likely to be sarcopenic. You'll see there's other significant risk factors in there as well, increased age, but things like reduced testosterone and increased CRP, so increased inflammation, were also significant predictors of sarcopenia. When we looked at clinical outcome, we found that firstly that sarcopenia, so this is, there's a couple of models presented here, I should say. So model 2 is the fully adjusted model. That's for the variables at the bottom. But what we found was that sarcopenia increases the absolute risk of all-cause mortality by about 33 to 37%. And this is regardless of whether they have CKD or not. So just being sarcopenic increases the risk of all-cause mortality. And there wasn't actually much of a difference between the CKD and the non-CKD group. When we looked at the risk of reaching end-stage renal disease, you can see that sarcopenic CKD people were twice as likely to reach end-stage kidney disease. And that was, again, adjusted for different variables. So, like I said, what we found, there was actually no absolute risk in all-cause mortality, but that doesn't take into consideration the risk that already comes with having CKD. So what we're able to do then was look at the probability, the 10-year probability of survival. So this is a relative risk of mortality. And this figure here shows that probability of survival over the 10-year period. The blue lines are the CKD group, and the green lines are the non-CKD group. And you can see that in both groups, having sarcopenia was associated with a reduction in the probability of survival. It's going to focus on the CKD group. So what we found was that the 10-year survival in sarcopenic CKD was about 4% lower compared to the non-sarcopenic CKD patients. But what was quite interesting, that ultimately what we found was that having CKD itself actually has a far greater impact on survival than sarcopenia. So those without CKD but probable sarcopenia had actually a much better survival than those with CKD and without sarcopenia. I'm just going to spend the last couple of minutes just talking about some other data that we have. This isn't necessarily relevant to CKD, but I'm hoping you might find it somewhat interesting. So in March 2020, last year, the UK Biobank actually began to release COVID-19 data, including the data linkage to death registry. And all existing applications to the biobank were able to have access to this COVID data to facilitate knowledge into the disease. So what we're able to do is, using the same data set, we were actually able to have a look at the association of sarcopenia with COVID-19. Again, this paper is just under review at the minute, but it is actually as a preprint online if you wanted to read the full paper. So what we were able to do is we're able to define severe COVID-19 as a positive test in hospital or any death with COVID-19 on the death register. In the biobank, there was over 2,000 cases of severe COVID-19, and we compared this to the rest of the biobank in a whole population approach. And I'll just draw your attention to a couple of things on the figure. Again, these are odds ratios. So firstly, we found that individuals with probable sarcopenia were 64% more likely to have severe COVID-19. And then when we're able to look at having muscle mass as a measure, what's quite interesting is that actually having sarcopenia by itself didn't increase the risk. Obesity did, which is quite well established now. But what we're able to show was that those with sarcopenic obesity were almost 3 times more likely to have severe COVID-19. So just in summary then, so the prevalence of sarcopenia, probable sarcopenia, is approximately double in those with reduced kidney function in the biobank. There's lots of different factors, both modifiable and non-modifiable, that may influence this. And we know that sarcopenia is associated with an increased risk of death, potentially COVID-19 infection, and also progression to end-stage renal disease. So we know that the measurement of sarcopenia, particularly hand grip strength, which is advocated in many nutritional guidelines in CKD, should be incorporated into clinical practice. And the ICD-10 code should be used to identify those most at risk. And it seems that physical activity and exercise really remain the primary treatment and preventative treatment for sarcopenia in this group. So thanks very much for watching. And again, I'm very happy to answer any questions quickly. If not, please email me or find me on Twitter. Thank you.
Thank you very much, Don, for your presentation. Let's see if we have any questions. In the meanwhile, I'd like to ask you, Ton, about some definitions of sarcopenia. We have been moving from muscle mass into muscle strength. So how can we differ dynapenia and sarcopenia? And do you really believe, are we really measuring and talking about sarcopenia and not dynapenia? How can we handle with this these two terms, and the most experts like John Morley, they do not have a consensus on it. So what is your point and what do you think about it?
I kind of agree with what you're saying. Ultimately, what we're measuring when we measure low hand grip strength is low strength, isn't it? It's low muscle strength, which ultimately is dynapenia. I haven't really got an opinion on the criteria used. And I know the ones I presented here, there's the European Working Group, but there are also multiple other criteria out there. And I think the one thing that I've learned over the last many years of using these criteria, I used them in my PhD to assess cachexia, was that there needs to be some kind of consistency in using them. And that's why I always try and use the same ones as much as possible. To try and add some kind of consistency to the literature, because ultimately there's so, they're changing all the time. There's so many different criteria. But I think ultimately it's about trying to identify patients most at risk of whatever you want to call it, dynapenia, sarcopenia, frailty, etc. So you can offer them the most appropriate treatment, identify those at most at risk. So I don't think that, there is one definite criteria, one definition that should be used. I think as long as people are consistent with their use, then that's probably the most important thing.
Okay, thank you. I agree. We have a question from Shali Fang. He's asking you, why did you choose BIA over other methods for muscle mass assessment?
Yeah. So that's mainly because of so I'm going to show, I've got one slide because I usually get asked about the biobank. So I thought I'd prepare a slide just to show what the biobank was actually. So the biobank was a large cohort study conducted in the UK between 2006 and 2010 across 22 sites. You can see the map of the UK in the top right. And essentially patients or participants were emailed or sent a letter. The general population, they were asked to send an assessment centre visit. These were done in like sports centres and schools, and they just went around this huge circuit and they did various things. You can see they had blood pressure, physical measures, fitness assessment, blood, questionnaires. And they, in that assessment centre, they used BIA. So in the biobank, there is BIA measurement for almost 500,000 people, just because it was the easiest thing to do. I mean, what the BIA used is the one that you stand on the scales, you hold the handle. So it's very easy to do, very quick to do. I will say in our data, so BIA doesn't give you a measure of appendicular lean mass. It tends to give you a more compartmental model. So what we're able to do is, in the biobank, there is actually, as you can see on the left-hand side of the screen, there is actually DEXA data for about 150,000 people. And a paper published by Richard Dodds, who's a guy from Newcastle in the UK, he actually used the DEXA data and the BIA data from the biobank to create an equation where you could transform fat-free mass from the BIA into appendicular lean mass. And this was validated against the DEXA. So we used BIA in our data because we had the most data for that, but we did use a correction equation to create the appendicular lean mass measure.
Okay, thank you very much for your presentation, Ton, and thank you for your answers.
Cheers, thank you.
Thank you, Tom, for sharing your research. The next presenter is Špela Bogataj. Špela graduated from the Faculty of Sport, University of Ljubljana, and received her PhD in kinesiology in last year. She is specialized as a young researcher in the field of nephrology, and as a part of her dissertation, she investigated the effects of exercise training in hemodialysis patients on their physical function, blood parameters, and dialysis adequacy. Špela continued her work at University Medical Center of Ljubljana in the Department of Nephrology. She is also habilitated assistant professor in kinesiology at the Faculty of Sport, University of Ljubljana. Špela's research interests focus on determining the optimal exercise prescription to improve health in patients with chronic diseases, especially in hemodialysis patients. Her findings have highlighted the importance of exercise in hemodialysis patients, and many of her current projects use various exercise protocols to improve quality of life in those patients. As part of her postdoctoral research, she is currently working on new programs to study the effects of exercise and cognitive training on various outcomes in hemodialysis patients. Špela, if you are ready, you can start. Thank you.
Thank you, Daniela. Thank you. Okay, let me see. Share. Okay, do you see my presentation?
Yes.
Yeah, okay, great. So hello, everyone. Thanks so much for having me. I will present our study protocol about the effects of intradialytic cognitive and physical exercise training on functional status of hemodialysis patients. The number of elderly people is increasing worldwide as mortality at younger ages is decreasing. In addition, 50 million people suffer from dementia, and this number is predicted to increase to 152 million by 2050. When we talk about cognitive decline, it can range from mild cognitive impairment to dementia, and it can have a profound impact on an individual's overall health and well-being. Cognitive decline is more common in patients with chronic kidney disease treated with hemodialysis compared to general healthy population. Their cognitive decline is not only the result of underlying and accompanying diseases, but can also be contributed to their changed lifestyle after starting hemodialysis. As we know, these patients have to travel to a dialysis center every second day, where they spend 4 to 5 hours in a sedentary position. Most of them report post-dialysis burnout and fatigue lasting up to 24 hours post-dialysis. That is why they are less physically active, and they activate their mental function to a lesser extent compared to general population. That is why they are usually, they have lower physical and cognitive performance. Moreover, clinicians usually fail to recognize declining cognitive performance in hemodialysis patients, and that is why cognitive impairment is critically underestimated and not appropriately treated. Cognitive decline often begins in the early stages of kidney disease progression, even before the start of hemodialysis. And after the start of hemodialysis, the decline continues at a faster rate than in the general population without kidney disease. Patients with cognitive decline are limited in their daily activities and consequently have a poorer quality of life. A cognitive decline and impaired executive function can create problems with adherence to medication regime, adherence to diet and fluid restrictions, and can cause problems with ability to comply with dialysis schedules, problems with maintenance of independence and self-care, which can lead to death. Cognitive dysfunction also correlates with depression and frailty in hemodialysis patients. Up to date, no effective pharmacological drug has been developed to reverse dementia. There are some drugs on the market, but usually their side effects outweigh their potential benefits. That is why non-pharmacological approaches seem desirable to prevent cognitive decline in hemodialysis patients. For example, in the general population, physical activity, cognitive training, and diet have been suggested as possible strategies to protect from cognitive decline. In the presented pilot study, cognitive training and exercise training performed separately were able to protect hemodialysis patients from cognitive decline in psychomotor speed and executive function. With this in mind, it would be a reasonable step to combine both approaches with the aim to improve the whole functional status of hemodialysis patients. Cognitive training and physical exercise training have already been implemented and tested in the elderly general population, but interventions in hemodialysis patients are lacking. That is why we identified the following research problems in hemodialysis population. This is what is the effect of non-pharmacological interventions in the form of physical exercise and cognitive training to improve cognitive function in hemodialysis patients. And second, by using the combination of physical exercise and cognitive training, is it possible to reduce the level of frailty in HD patients? And third, what is the long-term effect of a short-term intervention on cognitive and physical functioning in HD patients? The primary goal of our research is to evaluate the effects of cognitive training combined with physical exercise on cognitive function, physical performance, and frailty indicators in the HD population. The project will also demonstrate how these measures are related to each other and the feasibility of using the innovative cognitive platform to apply cognitive training to hemodialysis patients. The knowledge gained from this research can be further used to develop appropriate interventions to slow down the cognitive decline and to vanish or reverse side effects caused by physical inactivity. We will conduct a randomized controlled interventional trial to examine the effects of intradialytic physical exercise and intradialytic cognitive training on cognitive function, frailty indicators, and physical performance measures in hemodialysis patients. After baseline testing, we will randomize patients into two groups, the experimental group and the control group. The experimental group will perform interdialytic cycling and cognitive training 3 times weekly for the period of 12 weeks. In the meantime, the control group will only receive standard hemodialysis care. The primary study endpoints will focus on the domains of cognition. We will assess them with the following tests, where the first test, MOCA, will only be used for screening for cognitive impairment, but the other three tests are more sensitive, and they will detect the change in working memory, executive function, psychomotor speed, and attention with their subcategories. The secondary study endpoints will focus on physical performance, we will assess it with 10 repetitions sit to stand test, store balance test, hand grip strength test, time up and go test, and spontaneous gait speed. Frailty will be assessed by Edmonton Frail Scale, quality of life by kidney disease quality of life short form, and we will also perform blood sampling. We expect that patients in the experimental group will progress and show better results compared to the control group, not only after 12-week training period, but also after 6 months without specific activities. So after 6 months, we will again test our patients to evaluate the retention effect. And at the end, I would like to use this opportunity to present our research group, which forms the bridge between University Medical Center and Faculty of Sport. In the University Medical Center, the researchers are based in the Center for Hemodialysis and Peritoneal Dialysis, where we have 70 hemodialysis patients and 30 peritoneal dialysis patients. The center is led by Professor Jernej Pajek, and our research group consists of nurses, physicians, dietitian and kinesiologists. The research group from Faculty of Sport is led by Professor Maja Pajek, and it consists of different kinesiologists and exercise physiologists. Thank you for your attention. And our study didn't begin yet, so if you have any suggestions, you can bring it on. Thank you.
Thank you very much, Špela, for your presentation. Good to see you again.
You too.
We have a question from Daniela. She's asking you, which biomarkers will you assess?
We will assess brain-derived neurotrophic factor, and we will also assess inflammation markers like CRP and interleukin 6.
Okay, perfect. Thank you.
These are yeah.
Okay, thank you for your answers, Špela. I have a question while the others prepare them. Have you already performed like a cross-sectional analysis to see if physical function and frailty and sarcopenia and these phenotypes are associated with cognitive impairment and function?
No, we didn't, but I read it in other studies that they found a connection. So that is why we choose to also assess these endpoints. So we will check if it like we can, with our intervention, if we can improve also frailty and other endpoints.
Perfect, thank you. Let's see if we have another question. Muhammad is congratulating you and asking, what do you think about the effect of cognitive function on mortality? Do you believe, is there a connection, link between cognitive dysfunction and mortality in these patients?
Yes, I think it is, and especially in hemodialysis patients, because if they have lower cognition, which can also develop into dementia, they can have, like I already mentioned, they can have problems to comply with dialysis schedules. They forget to take their medication, and they are less independent. So this all can lead to higher mortality rates in.
Okay, thank you for your answer, Špela. And a last question from me. Are you planning to assess also their families? Because as you said, if they forget to take medication or forget to go into the treatment or something like this related to cognitive dysfunction, it increases the mortality rate and other clinical outcomes. But family has an important role on their treatment. Are you planning to assess their family, and if yes, how are you going to do this?
Okay. No, we weren't like planning, but we'll consider it based on your advice. Yeah, families are, I agree that families are an important factor in the treatment of hemodialysis patients. And they can play a major role in their medication regimes, like they can like give them remind them to take their medications and to go to dialysis. But like for example, like we had a patient with dementia, and they sometimes forget, like during dialysis, that they are like there, and they start to like to they want to escape the chair, and
Yeah.
so yeah, it happens.
Okay, thank you, Špela. And a last question from Charlie Fang. Will you include or exclude those with cardiovascular disease, since they may have more chance to develop stroke, which is associated with higher risk of decline cognition?
Yes, maybe we will perform a stress test, like just to check if they can exercise during hemodialysis, but otherwise we can also just perform cognitive training with them and not exercise in case of like if something can go wrong.
Okay, thank you very much, Špela, for your presentation and for your answers. Hope to see you again at next GREX webinars.
Yeah, thank you.